Hello, my name is Yuval Shaked. I'm an associate professor at the Rappaport Faculty of Medicine at the Technion. It's an Israeli Institute of Technology in Israel. Our research focuses mainly on studying treatments in cancer. But the way we do it is basically not looking how the treatments affect cancer cells, but rather how they affect the host. What I mean by that, we are interested to see how the treatments cause side effects, I would say, to the host, but not the regular side effects that we are seeing, like vomiting or like hair loss or myelosuppression, but rather other side effects that are, I would call them silent side effects, that basically can change in a way the way tumor cells behave. What I mean by, when I say silent side effects, what I mean by that? What we found was that when you give treatment, basically the host reacts to that treatment in the same way that the tumor reacts. So in terms of the tumor, you obviously can see tumor cell death, you can see anti-tumor activity of the drug. But when you look at the host, definitely there are some activity in terms of, especially when you talk about chemotherapy, there are activities of a host cell death. But in addition to that, you cause damage to the tumor and you cause damage to cells. And immediately there is a response of the host to that treatment that basically generate factors and processes that may try to heal the damage that you caused. So basically any type of treatment for cancer that you will give can be chemotherapy, cytotoxic drugs, can be even targeted drugs, or even radiation. All these type of treatment of cancer that cause damage to the tumor will have another trigger, will trigger a reaction of the host to that treatment that will heal the tumor. So that would explain why tumors sometimes regrowth or become resistant to treatment. It's nothing to do with the resistance of the tumors to the treatment, but rather the generation of host effects, these silent host effects that I call them because they are not measurable, and that they can now explain this resistance to therapy. I think that one of the major issues that now we discuss in this meeting that I am attending, this metronomic meeting, is I try and identify those treatments that will not cause will not generate these host response effects, the host healing effects. And I think that, and that's why I actually got into the picture of the metronomic chemotherapy, because I think that in this type of treatment, you don't generate these host response effects. These treatments, basically, where you give lower doses of drugs and that maintained for a long period of time as a maintenance treatment, basically provide, I think, a basis to explain how they work in terms of why we don't see resistance to that type of treatment, why we don't see regrowth. You may not see response, but we don't see regrowth of tumors because at the main point of this treatment is that giving drugs in very low doses, non-toxic, I would say, or less toxic doses, and that's why I think you generate less damage into the tissue on one hand, but on the other hand, you control the tumor. But when you don't cause this damage, or when the damage is slowly going in, then you don't generate these acute, I would say, host effects that can now promote resistance and regrowth of tumors. So one way is basically doing it when you give drugs, and it could be off-patent drugs, and very cheap drugs, not costly like we know with targeted drugs, that can improve treatment efficacy, and basically patients can have them for a longer period of time than with other acute treatments, and that these patients can actually will not have the same side effects that you will see with patients that get other treatment modalities for cancer. So in addition to metronomic chemotherapy, which is one way to deal with that, because we know, or we actually identified some of these host effects, we now can identify drugs that are already in the market for other indications, that now we can repurpose them or we can reposition them into cancer drugs. When you give them, obviously, with conventional treatment. What do I mean by that? Let's say when you give chemotherapy X, you will get a host response effect Y. The host response effect Y is based on upregulation of a specific factor that is not known in cancer, okay? But it is known, let's say, in an inflammatory disease, that you already have a drug for this inflammatory disease condition. So now you can take this inflammatory disease condition, this drug, and you can combine it with the treatment for cancer, the treatment X for cancer. This combination treatment that on one hand will kill tumor cells by the drug that you gave for cancer, the chemotherapy drug, let's say, and at the same time, something that will block this host effect, this response, this reaction, this healing process of the tumor, using both drugs will probably enhance treatment efficacy, extend survival, and improve quality of life. But the idea is now not to develop new drugs, but use drugs that are already in the market. So these are these drug repurposing or drug repositioning, as we call it. They can support, in a way, treatment in cancer, and they can become additional treatments for cancer, and they obviously, I think, would benefit cancer patients with less toxicity than usual. So that's a big question, and I think this is a question that have been asked so many times, in so many ways, and since the declare of Nixon of the war on cancer, we're still not there. But I think that in the last couple of years, we have made a lot of breakthrough in cancer treatments, especially with immunomodulatory drugs. I think that metronomic chemotherapy, for example, is another way to show immunomodulation, because this type of treatment promote immune cells against tumor cells. That's another way to. So I think that in general, in the near future, we'll see more and more progress made in not only in cancer research, but also in cancer therapy in patients. We will definitely see it. We already see it. We see some breakthrough, very, very interesting, intriguing results from clinical trials. But in addition to that, I think that the future is bright for cancer. I believe so. I think that we know better, much better than we knew before. And with the perspective that I have so far, I think that cancer will not be a disease in the next 100 years.